This conference will now be recorded.
Okay, greetings everybody. Happy New Year. This is our AnCan high risk advanced recurrent prostate cancer group. We've been meeting for years actually, and we've helped a lot of guys, and we help each other, and it's been very successful. And it's your participation that makes it work, because as you know, guys are reluctant to talk about much. Um, Today's Martin Luther King Day, January 15th. And that's an important day. And I'm glad we honor it in our history. I'm wearing my Juneteenth Black History is American History shirt in honor of that. So let me mention our sponsors first, which we're very grateful for going into this new year, for their financial support. We are not beholden to them. We are not promoting their products, but if they come up, we talk about them and side effects and experiences with them and so forth. But as again, we're not particularly promoting them, but we're thankful that they recognize the value of support groups. So those are Bayer, Pfizer, Sumitovant, Blue Earth, Myriad, Telix, Foundation Medicine, and Johnson & Johnson. I'm not sure if all of them have re-upped for the year, but that's who it's been. And we're
You started recording?
Yes, it is recording. My name is Peter Kafka. I unfortunately don't live in the cold snap area. I live in Maui, Hawaii. But we've got our own chilly weather here, if you can believe it. I get no sympathy from any of you, I'm sure. But I'm moderating the meeting from Maui. I switched with Len. I was supposed to do it last week, but I had family here, and he graciously covered for me, and I'm covering his slot today. Russ Hoover, Larry Fish, anything for you guys tonight?
Russ here, nothing for me, thank you.
No, thank you,
Okay.
Peter.
No? And who else? Did I miss anybody else? Stan
Friedman.
and Gary Peters.
No, Peter.
Nothing for me, Peter. Thank you.
Okay. Well, we don't give medical advice here. We give peer support. I mean, we encourage you to work with doctors, and we encourage you to get the best doctors you can possibly find. I've had personal experience with this recently, and it really pays to have experts who really are on their game, because the local doctors don't always keep up with the times, and they can lead you astray and run around in circles. And as I mentioned in my last reminder notice for my low and intermediate call, I actually had one throw up his hands a few weeks ago and say, "I give up. I can't help you. You got to find somebody else." It's the first time that ever happened to me, but it can happen. So fortunately, I had some other resources, and I don't have the pleasure or option of giving up. So we've got 4 new people. We're gonna have to keep moving tonight to cover everybody and make sure everybody's needs to be heard is heard. I think Rick has a couple of opening comments regarding our chairman of the Joint Chiefs of Staff and his experience recently with hush-hush prostate cancer. Well, that should be no surprise to any of us. Some men just do not like to talk, and sometimes it can get you in some political trouble. So go ahead, Rick.
Yeah, I'll be real brief because of having 4 new gents, but this has caught our eye, and we are in the process of drafting an open letter to Secretary Austin that should get published in the next day or so, which we'll also try and get some press to, and it will be signed, I expect, by some prestigious people. I can tell you that some of the very best urologists in the country have actually reviewed the draft. Whether they'll sign on to it or not, I cannot tell you. We are not going to address the issues at Walter Reed, which we're pretty familiar with. The lacking the lack of protocol treatment at Walter Reed, that's a whole another issue that we'll come to at another time. But just be assured that we're on it for the reasons that concern most of you, which is this shouldn't be a big secret, and this is a real opportunity to save some lives and to educate people about prostate cancer.
Very good. I think I said Joint Chiefs of Staff. I guess he's Defense Secretary. So I stand corrected there. Okay, so the way we work, for those who are new, is we give space for anyone new to go to the front of the line, and I'll ask some questions to each of you in turn, and then you can express your concerns and issues and anything you want to bring up, and we will do the best we can to kind of air some of your situation and see if we can all help each other. Okay. So first person up is Daryl Rower. Daryl, where are you from?
Washington Island, Wisconsin.
Okay. And how old are you?
I'm 64.
64. Okay, right in the slot. And when were you diagnosed?
July 3rd of this past year,
past year.
2023.
Okay.
Yes, this past summer.
And can I ask you what led to the diagnosis? Were you symptomatic? And what did they find on diagnosis? Did they do a biopsy? Did they give you a Gleason score, et cetera, et cetera?
Sure. I had been doing regular PSAs for the last year annually, like we're supposed to. At my physical back in April of 2023, I had jumped outside the normal range by a little bit. I was 5 point something. So based on that, my primary care physician referred me to a urologist. I got into that urologist in June, around the 23rd of June, and my PSA had jumped to 9.4, I believe it was. So based on that, they wanted to do a biopsy, which revealed advanced prostate cancer. I'm not sure if that was all your questions, Peter, or if there was another one.
So did they do they did a biopsy?
Yes,
And
it confirmed advanced prostate cancer.
did they give you a Gleason score, like a 4+5 or a 4+4 or anything like that?
Yes, in most of the categories, I was pretty high, 4+5,
Okay.
I believe.
And then they probably gave you some scans, like a CT scan or maybe even a PSMA scan to see if anything had spread
Correct.
outside. And what did they find anything there?
Yes, I had numerous metastasized locations.
Okay. And then, so I'm assuming you're under treatment of some kind at this point. Is that correct?
Correct.
Where would they locate, Peter? Where would
Yes,
they locate?
they immediately
What do you want?
locations in the bone. I'm sorry.
Okay, bone mets. skeletal bone mets.
Yes, there's I'm sorry, bone what?
Bone metastasis, mets. We shorten it to mets, but it's metastasis. When there's
Yes,
when there's action
yes,
outside the
there
prostate, it's
was.
metastasis. Okay. Uh, and are you taking some kind of androgen deprivation drugs, Eligard, Lupron, something like that, and second line drugs?
Yes, I'm on Lupron injection, and I'm also on Becca oral.
Rebecca. Okay.
And then I have received one course of chemotherapy that I just finished before Christmas.
And that was like just docetaxel?
Correct.
Okay. Um, I'll ask you a couple other quick questions. Have they done genetic testing on you um, to see if there's anything that possibly could be driving the cancer? Um,
Yes,
and did they find anything?
they found no. They did 91 tests that they could run, which was the max, and it did not come back significant for anything.
Okay. And final, where are you being treated? In Wisconsin or in Minnesota? Where are you being treated?
Yes, University of Wisconsin at Madison.
Okay. And I'm assuming you have an expert medical oncologist guiding you. You're not dealing with a urologist, right?
Correct. I quickly switched after diagnosis and got started on ADT. I switched to Dr. Christos Kyriakopoulos out of UW-Madison,
Okay.
oncologist.
Okay. So I mean, you're amongst great company. I mean, we were all, I'm 9 years into this. You name it, I've done it. Surgery, 2 kinds of radiation, chemo, immunotherapy, on and off androgen deprivation for almost 10 years. So you are in a well-versed uh, company of all stars here. Um, and this is, even at the level you're talking about, a manageable disease. So what concerns do you have at this point? You're fairly new in this, 6 months in. Um, and as I said, it's a manageable disease, which means you've got to stay on top of it and work with the best doctors you can. And there are fortunately more and more management therapies these days that can be very effective. So I'm assuming that the Lupron and the Nubeqa have brought your PSA down to a lower level. What concerns do you have right now?
Um, I am comfortable with the treatment I'm getting. I feel it is good quality care. Um, I, I don't know if concerns other than I felt it was time I need support.
Got it. Well, that's what we all feel. Does anybody else have any questions for Gary here? Or Daryl, I mean.
Daryl.
What's the
And I
current
apologize on my
PSA?
camera, Peter, if you can't see me. It keeps
That's
fading
okay.
out or it not
We hear,
connecting.
we hear
Okay,
you fine though. Go
great.
ahead, Jeff.
What's your current PSA?
The last time it was 0.58.
Yeah. So it rose pretty quickly from, you said April to July. It went up from 5 to 9 something.
5.3
Uh,
to 9.4, something like
yeah.
that, to
So
June.
someone was moving pretty fast. So I'm glad you got on top of it quickly. And now the drugs are working.
Yeah.
Um, did you, so, and you've done a round of chemo. Are they going to do 5 more rounds of chemo with you?
It was 6 rounds, this first course.
Right.
I have bone scans, or a bone scan and a CT scan scheduled January 25th, so coming up a week from Thursday, along with a CT scan. So then I will meet with my oncologist the following Monday, January 29th, to see what he recommends our next steps.
Okay.
How many bone mets did you have, Daryl?
How many bone mets were there? Extensive or more than 5?
They listed the word that has stuck in my brain was innumerable.
Innumerable. Okay. I could see how that could stick in your brain. Yeah.
Okay.
And so they probably did a germline genetic test. Do you know if they sent any tissue sample away for what's called genomic testing to see if the tumor itself has any actionable genes? They would have sent that to a lab like Myriad or Foundation Medicine or one of the big labs that does more extensive testing on the tissue sample itself. Do you know if they did that?
Peter, I can't recall. I'm sorry, off the top of my head.
Okay. Well, put it on a question for your oncologist. Ask if they sent biopsy slides away to get just to see if there's any actionable genes that are
It's
not so
called
much inherited, but
somatic
developed.
testing. Somatic testing. SOMATIC. For the new gents, there's a chat window.
Sure.
There's usually a lot of things that go on in the chat window. It's those 2 little squares at the top. If you click on that, somebody will put in that chat window somatic testing for you. My guess is that UW-Madison, they did send away. That would be typical. They're pretty on the ball there. They've got some good docs. Just a couple of quick things. First of all, it's typical with chemotherapy that the first session is fairly manageable. Don't be surprised if the second session is less manageable than the first session has been. That is fairly normal. And some guys handle it real well for the first 4 sessions, and they get really slammed in the 5th and the 6th. Everybody's different, but we're here. We meet every week. Keep coming back to us. We will support you with all the different side effects that you are facing. Please put your email address, either send it to me directly, Rick Davis, or put it in the window or send it to the organizers so we can get you on our reminder list. We send out a reminder before every meeting, and that's it's more than a reminder. It's really a newsletter. So it has a lot of good stuff in it, but it also serves as a reminder. We also have a meeting which some of the new gents may be interested in, called Men Speaking Freely. That will meet this week on Thursday in this room at this time, and that is a meeting to talk about everything except treatment, because it's for men with all types of chronic disease. So we don't talk about treatment, but we talk about some very good stuff, and it's really a good meeting. I'll sign you up for all you guys up for it. If you don't want it, change it on the website. Don't unsubscribe. It'll take you off completely. So we've got plenty of technical support in this group. We've got the other type of support in the Men Speaking Freely, and some of that other type of support is present here too, but we don't spend as much time on it. So we got your back. As as Howard Walensky, who's drafting this letter to Secretary Austin, told Secretary Austin, we've got your back. So, yeah, anyone else have questions? We're moving a lot quicker than we normally do, but
Darrell, are you doing okay with the ADT? Are you experiencing a lot of hot flashes? Are you do you feel debilitated? Are you managing it okay at this point? The Lupron and the Nubeqa?
Not much in the way of debilitation, I think. Yeah,
You're-
not much in the way of debilitation or extreme.
Okay. Well, some of us, if things start coming up, ask us, because some of us have tricks to deal with hot flashes, because I mean, it's essentially taking out your testosterone, putting you into male menopause, and
Sure.
it's a very different experience for guys. So you tend to gain a little bit of weight right where you don't want it, around the gut. One key thing to keep in mind, though, is I know it's the middle of winter in Wisconsin, but if you can join a gym, if you've got exercise equipment, if you cross country ski, I don't know, keep exercising, keep moving. That's essential when you're on these androgen deprivation drugs. Um, it'll lighten your experience considerably and lessen any potential side effects. And you'll you won't necessarily breeze right through it, but you'll have a better experience. All of us, I'm sure, can testify to that. That exercise, particularly using weights, you're going to lose some muscle mass on this therapy. You just want to keep your body strength up. You want to keep your stamina up, your heart rate up. You just want to keep at it. Don't, because sometimes you'll feel like, oh hell, I don't feel like doing anything. I just want to take a nap. Well, you got to fight that urge. And sometimes if you can find a buddy to exercise with or some way to work with it, it sure helps and changes things. Anybody else have any comments?
Yeah, Peter, just a quick note of encouragement for Darrell. You are getting the state-of-the-art standard of care, so you're in good hands with your oncologist and your medical team. So just follow their regimen, listen to Peter's advice on diet and exercise, and I'm sure you'll do well.
Did have as far as the chemo?
Thank you. That's very reassuring to hear. And just so you guys.
Russ, did you have something?
Yeah, just in case you had, so going through chemo, have they talked to you about icing your fingers, icing your toes, even icing your head as a way to reduce neuropathy and reduce hair loss? It's something to keep in mind.
Yeah, if you look on Amazon, that's what I did. I bought this little, it's like a headpiece that you can insert these little ice packs in. And cold therapy, ice therapy works really well while they're infusing the chemo drug, the docetaxel into you, because later on you could get a little bit of neuropathy in your feet or your hands, and this can ward it off. And neuropathy doesn't go away too easily after chemo. So there are some little tricks. I think there's something, it's called an ice cap, ICEKAP, and I think it's pretty inexpensive. You can find it on Amazon, something that's made in Canada, actually. Anyway, so I even though I live in Hawaii and Maui, I spend 5 months of the year in Minneapolis, and I'm being treated at the University of Minnesota with an excellent doc there. So there's a number of us that are pretty close to you across the border in Minnesota going through some of this stuff. So you're in good company. And, we'll keep in touch.
How did you hear about it, Darrell?
Thank you.
Off the web.
Just the website.
Okay. Somebody
Yes.
direct you to the website, or did you find it just Googling?
Hi, Eva.
Yeah, just Googling, and actually one of my adult children was very helpful as well.
Glad to have you on board,
Oh,
Daryl.
so,
Thank you.
Daryl, you just raised something, and this is for all of you guys, all the new men. If you have sons, and they are over 35, we recommend they get a baseline PSA test. I know it's younger than they suggest, but if you've been diagnosed with advanced prostate cancer, they're at very high risk. And at least at 35, they have a baseline. They don't have to have a digital rectal exam, but we really encourage. And if there is anything there, we'll find out early, and they can repeat it again in a couple of years, and they'll have that baseline level.
Okay. So Daryl, my email, I'll put it in the chat window, is peterk@ancan.org. Rick's is RD, or Rick Davis at AnCan.org. And there's a number of us that take turns moderating this. But if things come up and questions come up, what you want to talk to your doctor about, or something that you don't understand and you don't have time with the doctor enough, and we don't pretend to be experts, but we've been doing this a long time, and we can help each other muddle through some stuff, because it's a rapidly changing field, and with a lot of new therapies and treatments, and sometimes it can get confusing. So reach out anytime you want to us, okay? peterk@ancan.org or rd@ancan.org.
Very good. Thank you.
Okay. Okay, we're gonna move on to Stephen Roberts.
Hi.
Hi. So you got the drill, yeah? So
Yeah.
Stephen, where do you live?
Chantilly, Virginia.
Excuse me, where?
Chantilly, Virginia.
Chantilly, Virginia. Okay. And how did you hear about us?
I was referred from a local support group.
Good. And so tell us a little bit about yourself. How old are you?
63.
Oh, 63. That's the sweet spot for this. And what led to your diagnosis? Were you symptomatic? Were you PSA
Yeah,
going up?
I was initially diagnosed in 2017. My PSA was going up the year before. I think it got to 7.9. They did a biopsy. I had I guess Gleason scores of 2.6 and 2.7, and they did. I had treatment, hormonal treatment, radiation, and radiation seeding that year in 2017. And then the end of last year, on my PS. Well, I'll stop and say this. After I had the first test, I remember the doctor saying, after he did my PSA, I think 6 months after, he said, I just remember him saying, like, I expected your PSA to be undetectable, but we're still getting a reading. We're just going to have to watch that. So at the end of last year, it started going up. And I had been dealing with the same urologist for about 10 years because I had issues with kidney stones before. And so he watched it for a couple of months, and then he decided to have me do a PET scan. And a PET scan came back, and it showed us a spot of, how do you say, metastatic? I don't know how to say it.
Metastatic disease, someplace
Yeah,
else.
yeah. It showed us a spot of metastatic on the lymph node outside of my prostate. And so then he's got me on the Eligaron shot. I've had 2 shots so far. I don't know. I don't know. He says it's he's got me. I'm seeing a therapist also because like 2 months in, every 2 months in after the shot, I get really like moody and depressed, and I just get some weird vibes. And
Yeah, well, we know it.
and he said it's me. It's not the medicine. So I don't know. And now I'm in the process of trying to get a second opinion on the doctor because the last time I went to see him, he asked me how I was doing on the Xtandi, and I was like, "What are you talking about?" He was like, "The Xtandi." I said, "You never subscribed anything else to me." And he was like arguing with me like he did. And then I made him pull up my file, and and then he saw that he never he never prescribed anything else. So I'm in the process of trying to get that filled now. He put me on Xtandi now.
Okay, well, one of the first things that guys are going to mention to you is you need to get a better doctor. I'm not being critical of the one you have, but you're beyond a urologist. You've got recurrent disease. I mean, it's come back after treatment, and you were diagnosed pretty young. That's not always a great sign. You were in your 50s, mid to late 50s. So you you want to get a medical oncologist, and people will suggest tonight that you get an expert medical oncologist, which is called a GU medical oncologist, genitourinary medical oncologist. That's a medical oncologist that specializes in prostate cancer, diseases of the kidneys and urinary system. So, and because you're in Virginia, you're in a good space because there are some excellent places where you can seek treatment. Um, you're too
Yeah.
young for You're too young for Medicare. What kind of insurance do you have?
Well, yeah, that's the other thing. Unfortunately, I got laid off from my job last year, so I'm on actually Cobra now. So I'm on like Anthem, Blue Cross Blue Shield. I'm paying a Cobra. Uh, you know, that's where I'm at now, and I'm probably going to have to go on ACA. I can't continue to pay Cobra, but right now I'm paying $900 a month for Cobra.
Okay. Is Chantilly, Virginia on the eastern side or central Virginia?
Yeah,
What?
I'm like 25 miles west of Washington, D.C.
Oh, okay. Okay.
So let me just jump in here because I think Jim Marshall wrote to us that you might be on the call. Jim isn't
Yeah,
on tonight,
right.
but he did give Peter and I a heads up. Couple of things. It is not such a great area, in fact, for genitourinary medical oncologists. I'd have to disagree with Peter. The choice is pretty limited. The medical oncologist that we would recommend that you try to get to is at Sibley in DC. And her name is Palla, Channing Palla. I'll put it in the chat window, and I'll put a link for her in a moment. Would not suggest, for a number of reasons, the woman at Innova Share, although there are a couple of other medical oncologists that might be better, but I'd steer away from Aragon Ching if it were me personally. You do need, I mean, I'll go beyond Peter. Your urologist is clueless. If he doesn't understand that giving you Lupron injections is going to, it might cause depression, he doesn't understand Lupron, and he shouldn't be giving the injections. The problem is that those injections make money for the urologist, and they give them and they don't understand what they're doing, which is a big problem for us. And AnCan per se is critical of urologists that get themselves into treating advanced medicine. It's pretty common for men as a result of having these shots to suffer depression and anxiety because the lack of testosterone changes the receptors. So go ahead.
Well, this is the first time. This is in talking to Jim, he kind of alluded to that, but I'm like already 6 months in, and this is the first time I'm hearing this. I thought it was me, something wrong with me. Because
No,
my
this is
doctor was
No.
telling me, oh, no, it's not.
nothing wrong with you at all. One of the things that you can be doing, and we recommend, is talk to your PCP and get yourself onto some antidepressant medicine because that will help. And this is not you. It's not you that's causing this depression. It's the medicine that you're on. There may be some aspect to you, but the medicine you're on, we can track it directly to that. And so that's really how did you say you were diagnosed? The recurrence was diagnosed, an increase in your PSA?
Yeah, it started going up the end of December. I think, like I said,
Right.
after the first treatment, it never was undetectable. It was
Right.
always, and then I think it was like 0.9. And then
Right.
last year it started, I think in December it was like 1.5, then we went 1.7, but it went all the way up to 2.7 in
Okay.
May, and that's when I had
So
the.
let me ask you, did they do a PSMA? Has this urologist done a PSMA scan on you?
What's that?
Okay. Have they scanned you to see how extensive your metastasis is or
Yeah,
where the disease is?
yeah. I, he called it a PET scan.
Okay. What type of PET scan you'll need to find out from him what type of PET scan because he hopefully did something called a PSMA scan, but there are other types of PET scans too. And did they find anything when they did the PSMA scan?
Well, I saw the picture. It just was a picture. It had a little dot and an arrow pointing at the dot and saying that's what you know they said it was. That
Okay,
spot.
so on this picture they showed one spot, is that right?
Yeah.
Okay. So there are options as well in terms of the treatment too, but evidently this urologist hasn't discussed those options with you. Did he talk about radiation or not?
No, he just said, the only thing he just said to me was, "Oh, we're gonna put you on a shot that you'll have to do every 4 months for a couple of years just to keep your cancer under control."
Right. So there are other options, but you've got to get your ass out of there. And do you have, as I recall, your Cobra was over in November, or was that when
No,
it started?
that's when it started,
Okay.
September
So
actually.
if you can get yourself up to see Dr. Palla, and if you can't get into Dr. Palla, come back to us and talk to us again, and we'll find somebody for you. But you've come to the right place. And again, we'll support you the best we can. We'll get you to the right docs. And you've got loads of options. You don't have, even though your disease has come back, it's come back in a very manageable fashion, but it's got to be managed right. And, the prescribing those two drugs is the right thing to do, except he forgot to prescribe one of them. So that ain't so swift.
Well, yeah. Well, then when I went back, then his PA said, "Oh, he must have misspoke because we don't put people on Xtandi until after their first or second Elegant shot."
Yeah, well,
I'm
that's also wrong. That's also in error because that's not what the protocol says. That's not
yeah.
what they're supposed to put them on after their first. So not only doesn't he know what he's doing, but his staff doesn't know either. And if they want to find out, they can talk to me. I'd be happy to point out to them where in their own AUA guidelines it tells them what to do. But they obviously haven't read their guidelines for a while. So
Can
anyway,
can someone stick Channing Fowler's
yeah, I'll do it. I'll
website
do
on
it in a
or phone number on there?
yeah, I'll
Yeah.
do it in a second, Peter.
Okay.
Any questions for anybody or any advice anybody has for Stephen? Nobody? Nada?
Well, Stephen,
You
as I
said
said,
it
you want to
already, but
stay.
you said it already, but it almost for us, it's very kind of uncomfortably mind blowing to know that a doctor would tell you that side effects from testosterone suppression are in your head and that they're not caused by the drugs. That's insane. And
Yeah.
so
He
that's
just mentioned hot. All he told me was hot flashes. He just said, "Oh, hot flashes, and you might feel tired."
yeah,
That's all.
that's still insane.
Mm.
We get out of there.
And come back, we meet once a week, Stephen, and come back, you'll learn a lot and you'll get very comfortable with the disease, believe it or not. You'll get well educated and just hang out with us and just listen and you'll learn a lot. And we've got your back.
Oh, thanks.
Cobra's good for a year and a half, right, in Virginia?
Yeah, I think 18 months. Yeah.
Yes. So that'll almost get you to 65.
Yeah. Yeah. That's what, as long as I can afford the $900 a month, I'm good.
Yeah. Do they
You
have
probably
a marketplace, like
Yeah.
Affordable Care Act in Virginia?
Yeah. I actually did sign up on that because I think today or tomorrow is the last day, and I got a price. Yeah, and I think it was like $200, and right now, I think I'm just gonna let it overlap for 1 month just to make sure that I'm not gonna lose something if I go one way or the other.
Yeah, I was going to say the Affordable Care Act, you might find something cheaper than the Cobra, but Cobra's
Yeah,
pretty dynamite too.
yeah.
The other thing is, and we don't have time to get into it this meeting, but come back, we'll talk about it. You can bring it up, but you can apply for SSDI, although I don't know that it'll get you to Medicare any quicker. Probably it may do, it may not. It's going to be much of a muchness. But Stephen, please put your email address in the chat window or send it to me personally, and to make sure you get the reminders. For everybody, next week's meeting is on the Tuesday. We meet on Mondays, 8 o'clock Eastern, first and third week, and Tuesdays, 6 o'clock Eastern, second and fourth week.
Jeff, you have a comment?
Yeah, when he mentioned his Gleason, he says the second one was 2-7, and I'm wondering if the Gleason's a 7 Gleason is either a 3+4 or a 4+3. Do you know which it was?
I had 2 cores with a Gleason of 3+3, 1 core with a 3+4, and 1 core with a 4+3.
Okay. That means you're a 4+3, really.
Right.
So it's
Right.
not too
And
aggressive.
it could have been misdiagnosed at the beginning. You don't know with with biopsies, it could have missed something. I mean, if he had treatment and it never went undetectable, it's we don't know. You just got to work with what we got now. And it is recurrent.
And just one other thing, this is for all the new guys. If you haven't had testing for an inherited mutation, or which is also called a germline mutation, I'm going to put a website in the chat window, which is for a clinical trial. The testing is free, and it comes with a consult with the genetic counselor. And we recommend you do it if your doctor hasn't done that, and then we can talk about somatic testing at a later date. Certainly for you, Stephen, I would say just, the germline, and I doubt that your urologist has done this, but he should have done. Again, it's in the guidelines. So there's the website. It's called the Promise Trial.
Yeah, I don't think I've done anything like that.
And
And
gents,
yeah,
anybody can click on those links. It'll open in your browser. You don't have to copy it down. Just click on the link. It'll open in your browser, and you can look at it later.
So, Stephen, at this point, after this discussion, do you have any pressing concerns or questions you might want to ask the group?
Yeah. I just have one thing. I lost like 30 pounds, like not that I could afford to lose it, but like 30 pounds in the last 6 months. A lot of it was muscle, I think. But I just, I keep hearing everybody just talk about gaining weight, but it's just been the opposite for me. I don't know if I know I was eating very scarcely as well, so I know they had a lot to do with it. But
Well, you're undergoing a lot of stress. I can tell that, and that probably accounts for. Do you live alone? Do you have support with you? Or?
Yeah. All of this. I was caring for my mom that lived with me. She passed away. I got diagnosed with cancer. I lost my job. It was just all of this happened like within a 6-month period.
Yeah, I suspect a lot of it's stress related, and you're gonna have to learn to care for yourself. The weight gain is usually just around the belly, the gut, with these drugs, Eligard or whatever. But usually you're not going to gain a lot of weight, maybe 10 pounds, but losing a lot of weight's often stress related, and you certainly have the parameters for stress, and you're going to have to stick with us, learn to take care of yourself, eat right, perhaps change your diet, and these are things you have control over. These are not things that the doctor has to do. You have control over your exercise regimen. You have control over your diet. You have control over your mood and attitude to some degree. And those are places to start to get a hold of this, because you don't want to let this disease run away on you. And you want to be there. You want to be able to talk to your doctors and take some responsibility for the treatment plan and understand everything. Don't just say, yes, doc, fix me or take care of me. Because the best care you can get is when you help take care of yourself. So stick with us, and we'll give you some pointers, because we've all been through this. I know I've been on an antidepressant, low level 1, for 9 years, because this is a wild ride. These treatments and therapies and the side effects and the way it changes your manhood and how you've always thought of yourself and everything else. It's just spooky, and we gotta help each other.
All right, thanks.
Anybody else have any comments about weight loss at the beginning?
Lift weights, Stephen, and start rebuilding your muscle tissue.
Yeah.
Okay.
Okay. Well, we got your email. Stay in touch with us. If you have any questions, my email is in the chat window. You can call me up. Try to call up Channing Powler and see if you can book an appointment there at Sibley, right? Is that what it is?
In DC, she's in DC.
I believe so. Yes.
Yeah. Okay.
Yeah. She's in DC. Peter, you got to move on.
Okay. Where are we? Gary Keller and Dennis, in central New Jersey, someplace. How did you guys hear about us?
Well, I heard about it from Dennis. Where Dennis heard about it from, he'll have to let you know.
Okay, Gary, go ahead. How old are you?
Okay. Right now, I am 71.
Okay.
My case is one of recurrent prostate cancer.
Okay.
I was initially diagnosed in around December of 2010. The issue that brought it to the attention of me and my urologist was the fact that my PSA I was having PSA testing done by my PCP every few months, and between visits about actually it was a year apart, the PSA level jumped from 2.8 to 5.2.
Gary, you might want to add that in 2010 you had radiation.
I'll get to that in just a minute, Dennis. Thank you.
Okay.
Okay.
Peter,
So
Peter, why don't you ask the questions, because we've got to move quickly here. Okay.
Okay.
I'm sorry, Harry, but
Okay.
we got 4 new guys and we got a bunch of people that need time, so we got to move along at a clip.
So
sure.
they did a biopsy in
So
2010?
I went to a urologist. He recommended I have a biopsy taken. Honestly, I don't recall what the readings were, what the results were, but in the end, I decided to have radiation therapy through Hackensack Medical Center, the John Thurber Cancer Center, tomotherapy, which happened in March of 2011. I had about 30 treatments, about half an hour each day. At that point, I was thought to be cancer-free, rang the bell, and everything was okay for a while. Went back to my urologist every 6 months for a little while. PSA was pretty steady. After about a couple of years, we stopped going once a year. So it was instead of once every 6 months, was once a year, then up to once in 5 years. But I didn't feel I was getting the attention from my urologist that I had thought I should be getting. My PSA was pretty steady, but it was rising slowly over that period of time. When I switched to the new urologist, that was in February of 2023. That's Dr. Andrew Siegel, who I saw on one of the lists last week. Was pretty prominent in the field. He took my PSA and found it to be 4.4. That was higher than the 2.8 that was found about 6 months earlier. He did a retest. PSA was 4.2. Then put me through, he had me meet with his surgeon to give me my suggestions. Oh, sorry. Before that, MRI, PSMA, biopsy, found a localized cancer on one side of the prostate, one spot. Sent me to his surgeon, who suggested cryotherapy along with hormone therapy. I mentioned that to my PCP the next visit. He suggested going to Valley Hospital to their group, which they have a consultation group made up of a urologist, medical oncologist, and radiation oncologist who met with me individually, then brought it into a group discussion and came back to me, each one of them individually and the group, saying that radical or cryotherapy or any other procedure was not something that they recommend. They would recommend watchful waiting and just measure my PSA every 3 months from my PCP and my urologist, who has me now once every year, and just look for radical or major changes, jumps in the PSA readings. After the radiation, I had no signs of urination problems, frequency or stream or anything else, no side effects whatsoever. And now with the recurrence, I still do not have any problems with the stream or frequency or anything else. I have no ill effects. And the last PSA reading from my PCP after I went to the urologist was in the ballpark of 4.4 where I was back in February.
Very good.
Right now, I'm just looking for another way to go.
Sounds like you've got low grade recurrence, um, and they might be on the ball. You said you did talk to a medical oncologist at this practice, yes?
I did. Matter of fact, what I left out because I was trying to get finished a little bit faster than everyone else's, because I know we have to move along. I sought out another opinion because first I now have a suggestion of cryotherapy with hormones. Then I have a second opinion of watchful waiting. So I went to another surgeon in Manhattan, Dr. Ash Tawari at Mount Sinai Hospital.
Okay.
Okay, got his opinion. He suggested radical.
What a surprise.
Right. But he did have me see or take a.
I'm just, we've really got to move along here. Let me just summarize what the understanding is. Sorry to interrupt, but we got to keep moving tonight. It sounds like you had treatment in 2010. What was your original Gleason score? You didn't tell us that. Was it a 3 plus 4?
3 plus 3.
3 plus 3 was your original.
Yes.
So as far as you know, you knew at the time it was a 3 plus 3. So you had treatment, and it took about 13 years, but it came back. You're now 4 plus 4, 4.4, and they think that there is some cancer in the gland. Is that right?
Yes.
Okay. First thing is we don't do watchful waiting, ever. We only do active surveillance, even on recurrence and at the beginning. Watchful waiting is not a phrase that should ever be used in prostate cancer unless you're a very elderly gent and possibly on hormone therapy. We do not do watchful waiting. That's so anybody who used that term, I would be suspicious of, because obviously you heard it, you got it from somewhere. Secondly, have they done any PSMA scans?
Yes, they have.
And what did the PSMA scans show?
Showed exactly what I described before, which is the localized in the prostate.
Okay, so the PSMA scans only showed what's going on in the prostate, right?
That is correct.
Right.
And they also did an MRI and found no spread of the cancer anywhere else.
Okay, so no spread and just a recurrence. It's unusual. You're not the first guy. We've had a few guys like this recently where it seems to have come back just in the prostate despite having had treatment. So if it were me, I would probably still involve a medical oncologist, although it's questionable. In terms of surgery, they can do surgery, but it's a very difficult procedure once the gland has been ablated with radiation. So they can do it, and probably somebody like Tawari will tell you he can do it, but I don't know how good a decision it is. Third thing is, do you want to leave it there or not? Again, the problem is we don't really know what the original Gleason score was. Probably was not a 3 plus 3, because if it had been a 3 plus 3, it would have responded to this treatment. So there's probably some 4 in there. I think that if it were me, what I would be doing is going to, rather than a GU med-onc, I'd go to a really good radiation oncologist. I think Dennis, are you seeing Zalewski?
Yes.
Yeah, I would get an appointment with Zalewski, and I would put my cards in his hand, and I would follow what Zalewski says, because he's the sort of doc that if something can be done, if he thinks focal is right, he'll guide it to you. We don't like focal treatment here for a number of reasons, and but this is sort of salvage focal, so it's a little bit different. salvage focal, I would say, is a little bit different. But I think that the bottom line, I think, would be to get to somebody like a Zalewski, because he has the knowledge and the background and the experience to manage a situation like yours where the disease has recurred after radiation. Anybody else have anything they want to add? Len, anything on your mind?
I completely agree with your advice, Rick. Who said they're going to Zalewski? Was it Dennis?
Yes, I'm seeing
Yes.
Zalewski.
Yeah. Did you have to wait to get an appointment, or you got it quickly?
I got it quickly. And in fact, I mentioned it to Rick earlier in another meeting, but on Wednesday I have a procedure to have the space gel inserted in
Right.
for the radiation.
All right. Good. So yeah, I would go to Zalewski as well.
Yeah, in your situation, when you've already had IMRT, 30 sessions of IMRT radiation, it's doubtful that they'll do any kind of radiation again. But so in this situation, it could well be that they might be able to do something with cryo or laser ablation, and just target this one spot and get away with it. And it could buy you, many more years. So, but again, I echo that too. I would go to the expert who's had experience with this kind of recurrence. I think you're in pretty darn good shape. I mean, you were diagnosed pretty young in your 50s. Probably maybe didn't even need radiation at that time if it was a true 3+3, but you did it, and it's water under the bridge.
Mhm.
But I wouldn't get too excited or panicked yet. It certainly doesn't sound like runaway recurrent disease. I think it's going to be very manageable.
Thank you.
Anybody else have any quick comments?
I was going to say Zalewski may even say, no, you shouldn't have radiation again to that area, and you should try maybe 6 months of hormone therapy. So don't be surprised if you get that opinion.
Okay.
That's it.
Thank you.
Okay. Do you have any other big concern, Gary, that you want to bring up to the group?
No. You were right. Based upon what you said and listening to everyone else, my situation is not as dire as I thought it was. So thank you very much for
Yeah.
your input and your advice.
Yeah, good for you. I mean, you're 13 years into this, and you were diagnosed young, and hopefully you're doing okay.
So far, thank you.
Okay, Bill Lee. You ready?
Yep, Billy, I'm here. Auburn Hills,
Okay,
Michigan.
Bill. And Bill, where are you from?
Auburn Hills, Michigan.
Okay. And how old are you?
I am 62 right now. And I've got everything laid out, so don't ask any more questions. I can run right
Okay,
through
go.
here.
Okay,
Speed
shoot.
right up.
Tell us about it.
My journey started in March 2020. Diagnosed with stage 3A colon cancer. Had 4 cycles of, had the resection done, had 4 cycles of K-Pox chemo. Got done with that, called my primary doctor and said, hey, I haven't seen you in a while, so I'm coming to have you get caught up. So he did the blood test and all that, and he gave me a call. This was in August of 2020. He said, I don't like your PSA. I said, okay, well, what's it supposed to be? And he told me. And I said, well, what is mine? He goes, and I laugh when I'm listening to all you guys, not that it's funny, but you're all coming in with 1s, 2s, 3s, 4s. Mine was 49.42.
Right.
So then he went to the urologist. He gave me antibiotics just in case the colon cancer issue was causing some inflammation and infection. And had a second PSA test in September, and it was 66.11. So then we did a biopsy, and they did the poke and hope method. Out of the 12 cores, only 3 came back with cancer, and it was 3+3. Gleason 6. And he said, oh, we can wait and watch. Yeah, Gleason 6, you don't have to worry about it. And I said, yeah, wait and watch it go to my bones. My wife said the same thing. And I said, I'm young. At the time, I was 58. So let's, of course, we didn't know what we know now, but I went with the radical prostatectomy. And it was a good thing I did because it was actually a T3R1, Gleason 4+3, Gleason 6, grade 3. Pattern 4 percentage in Gleason 7 was 80 to 90%. It was in 40% of the prostate. I had positive margins, urinary bladder neck, grade 4. My prostate was 52 grams. So after that was done, I never did go down to non-existent. My June PSA of 2021 was 0.18. Then in January of 2022, PSA was 0.40. Then in March of 2022, it was 0.64. So that's when they said, send you over to a radiation oncologist. And I ended up doing 40 sessions of radiation. Then in September of 2022, I had a TIA where I lost the right field of vision in both eyes for 12 hours. That was fun. Then I had a good test, cardiac calcium score of 0, so my heart's fine, arteries are good. Then June of 2023, my PSA is at 0.99. And then here in December of 2023, his PSA is 2.02. So it's got a 5.9 month doubling time.
So Bill, have they done germline genetic testing on you?
They did all testing, and they said nothing they could find. They'll hold on to the samples and give me a call if they find something later on.
Okay. Because the reason I ask is I have a genetic mutation that's more than likely driving my prostate cancer, but it's very rare. It's called Lynch syndrome.
Yeah.
And I've been dealing, but it's for colorectal cancer, it's a flip of the coin. It's a 50% proclivity. So I have to do colonoscopies every year.
Right. They did that test with my colonoscopy also, my colon cancer. So.
And there's no genetic mutation that they found. Okay. I just wanted to ask because it just sounded too coincidental. Do you have history of cancer in your family?
Then during all this time, my wife came down in January of 2021 with glioblastoma, brain cancer, and she passed away January of 2023.
I'm sorry for that.
So you've had a fun time with cancer.
Do you have cancer in your immediate family, parents, brothers, sisters?
Both. Well, my sister had breast cancer. Both maternal grandparents had colon cancer. We're pretty sure my dad might have had prostate cancer. He had an enlarged prostate, but it was never tested, and he passed away quite a while ago.
And where are you being treated in Michigan?
It's a private practice, but it's associated with Wayne State Urology. Also part of
Carmenos? Are you at Carmenos? At Carmenos?
Carmenos,
are you at
yes.
Carmenos?
Yes.
And who are you seeing there?
Michael Char, CHER.
Is he? What is he? A medical oncologist?
Urologic oncologist.
Right. You want to get out of the surgeons, and what you want to do there. Here's the doctor you want to see at Carmenos. She's really dynamite. Elizabeth. What's her last name, Peter?
Oh yeah.
With an H.
H. Yeah.
Hold on a minute, and I'll get it for you. I'll give it to you. Elizabeth Heath. Okay. She is dynamite. We just sent somebody else to her who was actually with us last week. She's super smart. She's really compassionate. She's going to be tuned in to all these issues around Lynch and everything else. If you haven't been tissue tested, she's going to do all the tissue testing. And
like I said, I have though.
has your prostate tissue been tested?
Yes.
Okay. So I strongly recommend at this point that you move on from the urologist, and this is who you see, especially given where you are right now. You're at, what's your 2.02? Is that what you said?
2.02, yes.
Okay, so I would get your ass over to Dr. Heath as soon as you can, and I guarantee you're going to like her, and she will set you straight. Are you doing any hormone therapy right now, or are you still on no treatment?
Still no treatment. They wanted me to come back in June, do another PSA and a PSMA PET scan.
Okay,
that was the other thing. I've had a PSMA PET scan after the radiation, and there was nothing in there. Nothing.
But this is crazy. You're at 2.02, and they want you to come back in June.
Yes, that's the biggest concern I had.
You call them up tomorrow and get a plan with Dr. Heath. I've just put her details in the chat window, and come back to us next week and tell us how you're doing with her. We'll keep coaching you and navigating you. But I was, if it were me, I'd be wanting somebody to look and get me onto a plan sooner rather than later. How about the other moderators here?
I agree. She is a wonderful doctor. She's really on her game. Been doing this for years and knows her stuff, particularly with advanced disease. She's an expert, and you got to go with experts in this field, particularly when there's things going on that nobody else understands and they scratch their heads about and kind of put it off. So you want to be on this.
It's just disappointing that the urologic oncologist didn't refer you on. I'm not really sure why, but he didn't. But I don't think there's a lot more we can say to you right now in this group, because we can talk the treatment plan over with you, but you need support, you need navigation. We're here for that. But the first thing is to get you to a really decent doc, and I think we'd all agree that she fits that bill.
Very good.
Anybody else? Any other comments, questions?
Sorry for your losses.
Yeah, it's terrible.
Yeah,
Thank you.
I think we all are, Bill. And think about joining us in the Men Speaking Freely. All you new guys, think about joining us on Thursday in the Men Speaking Freely group, because I think you'll get a lot. I think you'll get a lot out of it. I know we're late, but David Muslin, you want to say anything else about the Men Speaking Freely group, since you're one of the moderators?
It's a place you can go to and show your vulnerability and listen to other men show their vulnerability, and it's a very safe container, and you'll be very comfortable being there. You'll learn a lot.
Thanks, David.
Very good. Wrote it down.
And come back next week, Bill. Bill, do we have you? Can we put you on the mailing list so that
I'm on the mailing list.
You are? Okay, great. Yeah. Okay, great. And we'll come back next Tuesday and let us know how you're getting along with Dr. Heath. I'm going to try and find her at GUASCO, because I don't really know her. I just know of her. But there's this huge meeting at the end of the month, and I'm going to be there, basically for the networking. And she's one of the docs that I really would like to seek out and just so that we know her one-on-one. We just sort of know of her, and we have guys that see her. but most of the guys that see her are down to us having sent to her. But she's good. She's been around a long time, and she's great. You'll like her.
Peter, Larry Fish has had his hand raised.
Okay, Larry, go ahead.
No, I was eating. I didn't have my hand raised. But as long as I'm talking, I think it's kind of, you've already got a PSA over 2.0. I think it's time for some sensitive scans and see what's happening, not to wait 6 months. It's ridiculous to wait 5 more months. I really think it's something could be spreading, could reach organs or all kind of stuff. They should find out where it is now if they can. It's enough PSA for it to show up.
Yeah, good point.
Yeah,
Well
like
taken.
I can tell people I feel like a cat in a rocking chair showroom. Yeah, every little pain hurts. I'm like, okay, what's that? What's that pain? What's that pain?
Yeah, I can imagine.
And my PSA when I found my disease was 340. So that has common with us. It's not
Yes.
an uncommon event.
And don't be afraid to change docs.
Okay, we got a few more. We got some guys we want. Who haven't been on for a while. Russ, up in St. Paul, update us. Tell us what's going on with you.
There we go. So I've went through the Alligard chemotherapy, abiraterone. It's been two and a half years now. Been 2.5 years of complete remission. No measurable PSA that is less than 0.01. This last test in the beginning of this month, and I was 0.03. But a year ago, I had dropped my abiraterone dosage from full 1,000 milligrams to 750. So I'm contacting Dr. Antonarakis on this. I'm going back up to a full dosage to see if it is affected by my abiraterone. But that's where I'm at. I also just felt like this was a good time to check other opinions. I did put in a request to talk to Dr. Sartor at Mayo. His team looked over my records and they said they'd be doing the same thing, same recommendations as Dr. Antonarakis. Then the other thing was I was at the men 60 and under group last meeting, and the subject of taking a abiraterone break also came up, and the questioning of the idea of just staying on this abiraterone, this androgen deprivation therapy, until I end up with something that's castration resistant. So the question was there, should I be doing something else? And so that's kind of what drove me to seeking a second opinion also. But so I'm just wondering what people think on staying on this androgen deprivation therapy continually, or is there some benefit or some theory that mixing things up is beneficial?
Well, I've mixed things up. Len, you've mixed things up. What's your take?
Yeah. Right. Peter and I have both taken multiple drug holidays. Like you say, a lot of oncologists recommend keeping the cancer off balance. Yeah, don't try not to consistently suppress your testosterone over years. How many years were you taking, Abby?
Well, the first like Alligard was 2.5 years ago. and I started abiraterone 2 years ago.
And what was your Gleason score originally?
9, 4, 5.
9?
Yeah.
Yeah, so I mean, as long as you're comfortable going on a drug holiday and potentially watching your PSA rise a little bit, you can always go back on, or they can do a scan, see if there's something they can target with radiation, spot radiation. That's what Peter and I have done. But you have to be mentally comfortable with seeing your PSA rise.
Yeah. Okay. So then the idea is, I mean, when would you look at switching? So I can see taking a holiday and going back on, but is there a point where you kind of say, okay,
How you gonna come over here?
Well, usually they recommend PSMA PET scans now quite early, like 0.2. But if you get to that level, they can do a PET scan, see what's going on. And if they see something, like I said before, they can either suggest radiation therapy or they can suggest that you go back on hormone therapy. Hopefully you'll get a nice long drug holiday.
I see. Okay.
But that's my opinion.
Yeah. Okay.
And you could talk to Dr. Antonarakis about switching drugs too. Whether to stay on abiraterone or go on darolutamide, or whether that has any benefit or not.
Yeah.
I don't know. There's no studies to show that kind of stuff, but some of us have done that.
Yeah. Okay.
Can you go back to abiraterone after you've been on darolutamide?
Yeah. Can you switch back?
Yeah.
Can I leave abiraterone, go to darolutamide?
I don't think there's any rules.
Yeah. Okay. Okay. Well, I think that answers my questions. Thank you.
Can you ask them?
Lori, are you doing okay? I know you got some challenges too.
Yeah.
That's
what I wanted to know. How are you, Laurie?
Oh, I'm doing good. The Lord's been just strengthening me, and I'm actually doing pretty good up and around. And
yeah, she's had a double mastectomy, and her lymph nodes are clear. So
my lymph
all
node
good.
was clear. So
Good.
recover. I'll go on hormone treatment.
Pleased to hear that. Come on into that caregivers group and the under 60s group. We miss you, Laurie.
Yeah, I was thinking about joining that again. So
Yeah,
it's a good group.
Yeah, come on in. There is one thing I want to say to you, Russ, which is don't put any weight on the difference between 0.01 and 0.03.
Don't worry about it.
No, I mean it's too fine a difference at these low levels, and the tests just aren't that accurate.
That's what Mayo Clinic said when I called them about a second opinion. They said 0.03 is to them is undetectable.
Yeah, I mean 0.01, 0.03. It's just. I mean, if you feel it's going to make you that nuts with this far out, just tell them you only want it to 1 decimal place. Okay. I mean, if you're going to start getting anxious about it going from 0.01 to 0.04 back to 0.02, it isn't worth it. Tell them you want it to 1 decimal place. It's not going to make a difference in your treatment. You've got to have the head to see it to 2 decimal places or 3 decimal places. And if you don't, and if you don't, that's no fault of yours. But if you don't make yourself crazy with it.
Yeah. So that can be just noise.
Right.
Exactly.
Okay.
And get comfortable where you are. I mean, I'm 6 months out now from Keytruda. I'm on nothing. But my PSA is hovering around 0.78, 0.80, 0.79, and I'm really happy about that.
Okay.
The scan on Friday, but I can live with that.
Okay.
So, to me that means something's working. So I'm happy.
All right. That sounds good. Thank you. I appreciate the input.
Okay, Al Latimer.
Okay, quick update apropos to our discussions tonight about getting to the right doctor. I have contacted Dr. E's office and in process of getting the records there and getting an appointment set up. So that's really all I have to say tonight.
Okay. Well, you keep me posted. I'm having dinner with E on the 24th. So if there's anything that needs to be brought up, I'll make sure I mention it to her. I'm having dinner with Dr. E and Dr. Munster and maybe somebody else from our advisory board and maybe Dr. Carroll, but he's got clinic that day. So it'll be an interesting evening. Of course, for most of you here, I don't know whose phone that is. Peter's, I think. For most of you here, you don't know Dr. Carroll, but you have Dr. Carroll to thank for a lot of this PSMA testing and technology. He was Peter's urologist. He's probably one of the best 3 or 4 urologists in the country, and he's super smart. And he's also a big fan of Dr. Munster's. So.
And a big pioneer in active surveillance too.
Huge pioneer in active surveillance.
Yeah. So Al, I think you get the record of seeing more doctors than any of us. We can go to you for referrals probably pretty soon. I thought I was going to a lot of them.
It isn't just prostate cancer either, because I've had other cancers too. So I've been to the 4 corners of the United States being treated for this or that.
I know. You're gonna be the one we say. Well, if you want to know about a good doctor, go talk to Al Latimer. He knows them all.
Well, actually, I come here when I want to find that out.
Right. Well, let us know how it goes with Dr. E.
Okay,
I think you'll really enjoy her.
Andy's 20 plus years over.
Actually, I have met with her before when she was at MD Anderson. I met with her and she told me, before we do anything, you've got to go to UCLA and get a PSMA PET. And that started the whole ball rolling of me going to UCLA, having the PSMA, getting enrolled in the Pluvicto trial, et cetera, et cetera, et cetera. So that came as a recommendation from here back in 2020. So here I am, full circle. I'm back there again.
Yeah. So, one of the reasons we like Dr. E so much is because she'll send you where you need to go. She doesn't try to keep it in-house. She doesn't try to do it herself if she can't do it. She has the patient's interest at heart. And so you'll do great with her. So David Muslin, did you have something you wanted to say?
Yeah, how many years, Al? How many years you been at this now?
I was diagnosed in 1995. So last month it has been 28 years since I had surgery.
Okay, I'm going to call you.
28 years.
Yeah, that's awesome. You're the best. We got to get together. We got to get together in the next month or so. I'll call you and maybe we can get together with Dr. Jack too, or anybody else in South Florida. I'll get together and have a meal. Okay. But I'll reach out.
Okay, very good.
Thanks, Al.
Okay.
Yep.
Great, guys. Okay. Jeff Betts.
You're muted, Mr. Betts. There you go.
Yeah, not no more.
Not no more.
So, yeah, I know I've been a little ditzy about the information on my stuff, so I just wanted to bring it out. I found all my information. My PSA was 1138. March of 22, and my Gleason's was 3.4 and 3.5. I mean 3 plus 4 and 3 plus 5. By September of 22, I was down to 0.5 PSA, and from there it just kept going down, including today was my follow-up, and I was undetectable.
Yay!
And yeah, I was a little worried about it, but so that's pretty much what I wanted to say. Like I said, I didn't really have all that information before. I was a little loopy, so.
How have you gotten that somatic testing done, Jeff?
I have not. Honestly,
Okay.
I'm not gonna lie.
Okay, well, get on to Gelman and tell him you need somatic testing, and there's a good chance you can get a result with liquid biopsy just because of your tumor burden, even though your PSA is low. And
okay,
it's really, really important. I mean, it's something that it's protocol. It's what they're required to do, and
the
we
somatic
shouldn't have
testing.
somatic testing, which means we want to know if there's anything special in your tumor that calls out for a particular medicine. And even though you're undetectable right now, which is great, we really need to know this. And if not, we also need the baseline for this somatic test, because then we know where you are today versus where you might be a year from now. So you're still on the. I'm assuming you're still on the abiraterone and the Lupron.
Yep, I had that today, Lupron.
Okay. Well, just you got to ask them for it. Tell them, not ask them. Tell them, it's the protocol and you'd like it done.
I will. It's some guys were talking about the Lupron and how it affects you, and I'll tell you what, man, I had a hard time with it. So,
yep.
It took therapy and antidepressant to really get over it, but I feel so much better now, and I feel a lot more aggressive towards that. I'm going to hit up Gelman and find out about that.
Now, there's another discussion with Gelman, and I don't know Gelman. I don't know enough about Gelman to know how he'll respond to it. But there's a lot of guys, not a lot, but there's a number of guys in this group who are a couple of years out like you are and on the abiraterone. And one thing you might want to do, I'm not sure that you're a good case for a holiday at this point, but maybe going to abiraterone monotherapy and dropping the Lupron. And what that will do is allow testosterone back into your body. It shouldn't affect the cancer because you're taking the abiraterone, but it might just help you in other areas. And we've seen guys who have benefited from doing monotherapy abiraterone. It's not, I don't think, Len, there are no trials, right? There's no evidence, but
I think there was maybe a phase 2 that showed Abby alone was just as good as Abby plus Lupron.
Right.
But the thing, Rick, is that Abby is going to keep his T levels very low, just like Lupron. Abby, I think of Abby as like a super Lupron.
Right. But maybe you don't need the Lupron.
Yeah, I would talk to your doc about maybe dropping the Lupron because the Abby alone should do the job. Or if you want to switch to an androgen receptor blocker, then that'll allow your T levels to rise to probably normal levels, and you might feel a lot better.
Yeah, he seemed really concerned about the T levels because I wanted to try the blue pill, and he said that
Okay.
he advised against it because of, and when I looked it up, it only raises the T levels by like 0.3 or 0.03. I forget, but it was very little. Excuse me. So, but
You mean on a
I'll ask him
receptor
about it.
blocker?
No,
What was that?
Cialis, Viagra or
Viagra.
Cialis.
Yeah.
Oh. Okay.
So, but yeah, I will bring it up to him and see what he says about it. Things have been going pretty good, so it would be nice to be able to take a break from it.
Yeah.
Okay.
But these are the things about around sort of changing up, changing down, and that we want to put into his mind, because these too many of these docs are on autopilot. I just saw one, heard from one this week. I couldn't believe what she wrote back to one of our guys. And they're just not thinking. They're just prescribing without thinking. And so it's our job to make them think. And as far as the somatic testing is concerned, it's just that's a no-brainer. I mean, he needs to know.
Yeah, I'll check into that. I'll talk to the research people too that I deal with and see what they have to say. They seem to have a better time dealing with him.
Okay. Okay, come see us on Thursday in Men's Speak.
I plan on it.
Okay, and we are going to get together for a dinner in Tucson. I don't know when, but it's sometime soon. You better be there. Be there or be square.
Just
Bring
let
the
me know.
wife.
I'll
Okay.
absolutely be there.
Okay.
Okay, guys. Okay, let's keep moving here. Don Eisner.
I think he left.
No, I see him.
Yeah, I had
Oh
a
no,
brief
he's back.
meeting and I had to go. My day job called me. I'm going to be
Oh,
square because I don't know if I'm going to make it to Arizona. But
okay.
my discussion is actinium. I tried Pluvicto. PSA went from 65, 22, got off it. It went up to 65, and then I sort of took a little holiday and tried a few this and that. My PSA went up to 100, 200. I tried Jeftana, but I got the peripheral neuropathy, horrible, which I almost have it right now, pretty bad. I called City of Hope, and here's my big question. How dangerous is actinium-225 antibody targeting human kallikrein-2, HK2, for advanced prostate cancer? The reason I ask that is that I've heard of some of the horrendous side effects. Am I better off with the devil I know rather than, and it's never been used on humans, this particular brand of actinium. So any thoughts about that?
And what's it targeted? What's it targeting again? HK2, did you say?
It says H, little h, big K, little 2. Supposedly never used on humans, test tubes, maybe animals. They're looking for 132 candidates. I probably can get in, but as you know, you may have talked about this in the last few months, I think in April, the salivary glands, once they go, they're gone. You're done. You can't function. And they don't merely mention it. Between you and me, it's a little misleading here. I have a 38-page informed consent. And guess what? Buried in it, side effects, major kidney lump. And then on the next page, buried after another 5 or 6, dry mouth. Yikes. Seems to me that would be one of the biggest things they would tell you, So I probably not going to do this. Probably going to get more Lynparza. I'm on Lynparza, Zytiga. I'm going to up it a little bit and see what happens. Other than that, I don't know what else. Maybe.
Okay. So let's just pass this a little bit. first of all, where's your PSA level right now?
Oh, about 300 and something.
Okay. And did you respond at all to the Pluvicto?
I did. I had a fairly good result. I think a PSA, well, it was a mixed result because there's no correlation between getting Pluvicto and necessarily getting rid of the tumor spots. It gets rid of some, not all. New ones
Well,
can come up.
there is. I'm going there. Okay. So,
Well, let's say there is a correlation, but my PSA went from 65 to 22 at the fifth one.
right. So here's the question, and I don't know whether this is up to Schultz or whoever it's up to. Have you done a recent FDG PET that is compared to the PSMA scan?
I don't think so.
Okay, so do you know why I'm asking that question?
No.
Okay. The reason I'm asking it is because, and this is a pet peeve in this group, we say it all the time. So everybody listen, and everybody should be asking for this. We want to know if all of your lesions respond to PSMA. We know that they do a PSMA scan to make sure you're expressing PSMA. And if you're not expressing PSMA, they say, we're not going to give it to you. The problem is, what we don't know, unless they do the FDG scan at the same time, is how much or how many of your lesions are expressing PSMA, because it's not necessarily all of them. And in Australia, if you're not expressing, I forget whether it's 50 or 60%, but there has to be a large percentage that are expressing before they'll even do the Pluvicto. Now, in some of the trials here, it used to be you had to express in at least 50%. But what's happened more recently, because it's been approved, is the doctors throw the Pluvicto at you and they don't bother to check what is not responding. Why are we interested in what's not responding? Because we know that one of the characteristics of disease that is changing is that it doesn't express PSMA. And if you are not expressing PSMA, then that could be the sign of small cell disease coming on, and we have to treat that small cell disease. It's an advanced sign. So what we need is an FDG scan and a PSMA scan. We need to compare them. Now, the reason I asked you about this actinium-225 and what it was targeting is because if it's using PSMA as its missile, then it may not help you much. If it's using something else like this HK2, which I'm not familiar with, but I'm sure that people like Len or Dr. Jack or others may be familiar with, then it is a real option. So it's not the actinium we should be so concerned about. It's how the actinium is going to get to the cancer. Okay?
Right. Well, I will certainly discuss it with them. I also check with UCLA or Dr. Scholl's, see if I have the FDG. I don't know. I'm going to see him in 2 days, so I'll double check all this and see the risk benefit. If my PSA is going down with this Lynparza, which I think I have a BRCA mutation, by the way, a relevant one. It goes down to 200, 150, and I'm on the right
so
track.
let me ask you about that. What makes you, I was going to ask you why he's giving you the Lynparza, and what mutation has been seen from your somatic testing that makes them think Lynparza is appropriate?
I think we had the BRCA2. I don't have the list in front of me, but there were a slew of mutations I had. He said I had the relevant one. I think they also confirmed it. Two other doctors, I think, confirmed that I had it because I had some other consultations. So I'm 99.9% sure I have the relevant mutation.
Okay.
99.9.
So then give that, look, the PARP inhibitor is pretty toxic, Dan. That Don, it's, you know, it shouldn't just be given willy-nilly. So I wouldn't look at anything else. I would give the PARP inhibitor a chance if in fact you're expressing that BRCA2 somatically, which it sounds like you may be. Get a copy of that report. So, you know, let us take a look at it too.
Sure.
And get a copy of that, of the report that said that you're expressing BRCA2. I mean, don't get caught up with whatever this HK2 actinium is. And by the way, one thing we do know is that yes, it does affect the esophagus, and it does affect the salivary glands. But one of the things that they've actually done is they've given they've given one dose of the small molecule before the big molecule, and that seems to have helped in terms of the damage that's done to the salivary glands. But they're not gone for good. They come back. Ask Al Latimer. Don't, you know, if you're saying, oh, they've gone for good, but no, they'll come. It takes some time, but they do come back, right, Mr. Latimer?
Yes. The first time I had Pluvicto, I had 6 rounds, and by the time I was done, the the dry mouth was pretty severe. But in 3-4 months, it came back. I've now since had 4 more Pluvictos, and the dry mouth got bad again. I'm 6 weeks out from that, and I'm beginning to see it feel a little better. So I'm hopeful that that will continue. But I did recover completely from the first, well, 95% from the first round. And I seem to be recovering this time too. But my understanding is that the actinium is much more potent. But don't know.
Well, I've seen some scary research studies where 10, 20, 30% drop out because of the severe problems. That's a lot.
Yeah.
And
Well,
this
they're pretty
is
powerful
unknown.
drugs.
What?
They're pretty powerful drugs, for sure.
Right. But, you know, yes, it's true, but, you know, we're giving it to you firsthand from a man who's been through 2 cycles of Pluvicto.
Well, Pluvicto, I didn't mean to interrupt. I had no problem with Pluvicto, with the mouth. Not even barely a dry mouth that I would notice. Actinium could be 10 times worse, 50 times worse, exponentially.
Yeah. No, I mean, I don't know if it's exponentially, but it could be worse. We don't have enough. Jim Barnes just flew over to Vienna to get actinium, but we haven't heard from him since he came back. So I don't know how he's doing.
Yeah. Yeah, I'd like to hear from some people next week or the week after who've been on actinium. That would be interesting.
Yeah, I mean, I can only think of 2, and one of them's no longer with us.
Oh boy.
So, and the other one is Jim Barnes, and you know, we can put you in contact with Jim Barnes. But I think you should. If it were me, I would be focusing right now on the Lynparza. And you know, Len's just posted something, and I think what that's suggesting is that this actinium is being used with this HK2 as the antigen that takes it to the cancer, and not prostate specific membrane antigen.
Yeah. Lot to
Give
think
the
about.
Lynparza. How long have you been on the Lynparza?
Just a couple of weeks.
Okay.
Brand
How
new.
often are you monitoring your blood?
every week or two. I'm going to go in Thursday and get another blood test
Okay.
and
So
see what the
keep
PSA
a
is.
real close eye on that blood.
Yeah.
Keep
I
a
don't think he's
real
going to
close.
knock off. Oh, but I was going to say, I don't think he's going to knock off my Lupron, but that would be nice. We'll see. I'll talk to him about that. Yeah, I will talk to him Thursday afternoon, and by Friday, I'll see if my PSA went below 300. If not, maybe increase the Lynparza.
Len?
Yeah, I would, wait and see how you do with the Lynparza, because that's a proven therapy, provided you have the BRCA2 deletion. This HK2 is kind of a Hail Mary. It's a phase 1 trial. I think you mentioned it yourself that hasn't been tested in humans before. So that's a last resort, I would think. Now, I have heard that the actinium 225 doesn't affect the salivary glands as heavily if you use a large molecule like monoclonal antibody J591, I think it is, as opposed to a small molecule targeting agent.
That's
But
what I
anyway,
was driving at, Len. You got it.
yeah,
I was up the wrong creek. That's it.
yeah. And Carl Foreman had, well, actually, more importantly, what was the name of that fellow with, I think he has like a Norwegian name that died recently. He wasn't really part of our group much. Bryce something.
Olson.
Oh, yeah.
Olson, yeah, Bryce Olson. He had multiple actinium-225 treatments, and he claimed that his salivary glands were affected, but that he recovered from it. And I think it was because he was using the larger molecule that doesn't quite penetrate the salivary glands. So, something to consider discussing with your doc.
Thank you.
Okay, Don. Yeah, let us know how it goes with Schultz on Thursday. But he's had experience with a bunch of this, so he should be able to talk pretty straight up with you. You okay? Good. Okay, Chuck. Winding down. Last two people. Chuck, go ahead.
Hi. Thanks, Peter. So I just wanted to give an update on my Pluvicto. I had my second treatment last Wednesday, and I noticed after I got COVID. The second treatment got delayed by 2 weeks. So hopefully that wasn't a problem. My oncologist didn't seem to think it would be. But anyway, the first time I got the infusion in November, for the first couple of days, I had nausea, which went away on day 3. But this time, I'm getting much worse nausea and vomiting. I had 2 days of vomiting, the day after the infusion and the third day. So I'm just worried. Is this going to be cumulative? Every treatment I get, is it going to get worse and worse? I was just wondering if anybody had any experience as the treatments went on. Does the nausea and vomiting get worse or stay the same?
Al, what was your experience?
Chuck, this is Al. I assume they're giving you anti-nausea medication.
Yes,
as
they
an infusion.
They did. Yeah, they did. With the infusion, they did. And oh, go ahead.
Well, I was just going to say, Um, like I was saying a while ago, I've had 10 treatments now. I've never had an issue with nausea. So I'm
Really?
not, so everybody's different.
Yeah.
Yeah.
Okay.
I had vague side effects. I stopped after the fifth. I had nothing like you had. It's just a little, maybe I was tired or something. It was nothing major. I just didn't think I was getting enough out of it. And as it turns out, after the 5 treatments, then what? What do you do? That's my question.
Yeah, that's kind of where I am too. I'm wondering what's after the Pluvicto, because the doctor, it's kind of, well, I guess there's the second type of chemo instead of docetaxel, like what is it, cabitaxel or something, or I can't remember.
Guys, you've got to stay where you are right now. You've got to. If you start trying to figure out after you've had 1, maybe 2 doses of Pluvicto, you're going to make yourself nuts. If it's successful, and for some people it is, for Don it was less successful, but if it's successful, hopefully you can get 18 to 24 months out of it, and then maybe you can do it again, like Al Latimer has done. But you can't be thinking when you're just starting a treatment, what am I going to do next?
I know. You're right.
You gotta stay in the moment. Come over, come on in, Snyder, come on in on Thursday night. We'll talk to you more about this. But we gotta keep you in the moment. There's no question that the nausea is in the moment, and you've got to address that now, and we got to get rid of that nausea. Peter, you want to say anything about that?
Yeah, where are you being treated, Chuck?
NYU Langone in Manhattan.
Okay, well they'll have doctors that can treat side effects. They're specialized in that kind of stuff. And ask for someone to who's the good palliative care docs there, and they'll assign you somebody who can deal with they specialize in dealing with side effects and trying not to compound things for you. So ask who the palliative care docs are there and put them on your team.
Okay. All right.
Because every big institution's got some.
Yeah.
And they are the docs who stay on top of the best and the brightest of the drugs that are around for palliative care. The nuclear med doc is going to throw you out with, well, if you feel sick, take a couple of these, but that might not be right for you. And he might not have looked to see what that interacts with everything else you're taking. That's what the palliative care docs do. That's why we say to everybody in the group, if you've got advanced disease, get a palliative care doc onto your team as early as you can. They're not end-of-life docs. They're quality-of-life docs.
Yeah.
And they're here exactly for this, so that Chuck Snyder can call his palliative care and say, hey, doc, I got a problem. I'm feeling really sick. It ain't working. What else you got? What else you got in your bag of tricks for me? That's why we want you all to have a palliative care doc. Don't wait until you need one. Put one on your team now. I mean, the ASCO guidelines say that for people living with advanced cancer, even for people living with cancer, they should have a palliative care doc. So, but you've got to ask for that, because a lot of your physicians, they won't offer it to you.
Right. Okay. Thank you.
Okay. Good luck with that. Okay, we're making
Anyone else? I know Don Eisner had Pluvicto, and Len had Pluvicto. Sorry, Len. Al had Pluvicto. Anybody else experienced with Pluvicto here? Or any advice for? I know
Yeah,
Muslin has. I know Muslin agrees with me about staying in the moment, right?
I do, but it's easier said than done.
It's easier said than done. Agreed.
Yeah, one other thing I wanted to say is, concerning the dry mouth, I haven't had any dry mouth yet, but I read somewhere that if you put ice on your salivary glands during the treatment, that it may help prevent that. So the first two treatments, I put ice around my my cheeks and under here. So hopefully maybe that helps. If they said try it, can't hurt. So
Right.
Maybe that's helping with the dry mouth.
Let us know. And you got to keep your mouth pretty clean if it starts getting dry. Use Dr. Bob Gormankin has some papers out. He's a retired dentist from Philly, but he wrote it up. You got to use Biotine toothpaste and mouthwash. You got to keep your mouth really clean if you can start getting dry mouth, because you can get tooth decay very easily.
Yeah.
I thought I was taking care of it, but I didn't have a tooth pulled. I thought I was religious about it, but I lost one a few weeks ago.
Really? Okay.
And that wasn't Pluvicto, that was Keytruda, but still it's dry mouth.
I really found the Biotine product, especially as a dry mouth rinse. And the night when you feel dry mouth, get out of bed, take a little bit, go back, let it roll around on the tip of your tongue. It really helped me a lot.
Yeah. Yeah, because saliva fights tooth decay. So you lose it, and you leave yourself open for that. Okay, we got one other guy to get to, and we've done pretty well. 4 new people, and
Okay.
Peter,
I just want to say I'm going to put the link to the dental posts in the chat window. If you didn't see them, you can go to our website and just put in dental, which is what I just did, and I'll put them in there for everybody, so you can read them.
Okay. Alan Moskowitz.
Okay. Hi, everybody. Hey, I've got a very quick and hopefully a simple question. I've had recurrent prostate cancer and all. I had the surgery, the radiation, and I had a year of hormone therapy, Lupron and enzalutamide, ending in 2022. And so my PSA is still barely detectable. It's less than 0.1 as of last week. Not too concerned about it. But interestingly, my testosterone, it was starting to recover. My normal is only about 350 or 375, and it was up to 229 in June of last year, and it went up to 244 in September. And now in January, it went down almost 100 points to 156. And so what I want to know is this just typical? As T recovers, it can fluctuate, I'll say, very dramatically. I'm hoping it'll go back up to in the 300s. Yeah, I see nodding from David. Yeah.
Yep, mine jumps around quite a bit too.
Really interesting.
And I think I've heard it from other guys as well. I mean, mine can go up and down 100 points from where it was at.
Wow.
I've had as high as 700, and I've had as low as 350 or 400, and it bounces around.
And what's the cause of that bounce? Any ideas?
That I can't answer.
All right.
Maybe somebody else can.
I had mine drop because of prednisone. I mean, there's different things that can affect it seems, but I don't think there's any one answer to it.
Yeah. All right. Well, fine.
Well,
We'll see what happens over time.
So a couple of things here. First of all, Dr. John isn't in with us today, but I think he might be able to explain it better. I mean, we need an endocrinologist in here. Jack, can you do you have an answer? Can you explain as to why testosterone
Yeah,
moves around so much?
yeah. The one thing you can consider with testosterone alternating like that is that, time of day that you have the blood drawn. It's very important because in the morning, it's very pulsatile and it varies. So if you're gonna have it drawn in the morning, it's gonna be at the highest point. As the day goes on, it's going to diminish. So you should check when you're having the blood drawn and see if that may be making a difference in the blood
Yeah.
level of testosterone, Alan.
Yeah. Mine are only in the morning. They're the first thing before breakfast. So
Always the
there's
same.
consistency there. Yeah, it's interesting. Well, I'm not overly worried about it. But so basically, with a T of 156, which is considered below normal, do I basically consider myself to be somewhat vulnerable, if it stayed like that, to, I'll say, osteopenia, which I have, or muscle degradation if I don't keep up my exercise? I mean, that seems like it's low enough to put me on that border of I better be careful and keep the exercise level up. That makes sense?
Yes, keep it up anyway,
Yeah.
even no matter
Yeah, I'm
where your
trying.
T level is.
Yeah, yeah. All
Does
right,
not
that's
hurt.
fine. All right, I'm good. Thank you.
Go
Okay.
ahead, Larry.
So this is very interesting because my T level is like 0 for 5 years or longer, basically 0. But a couple of years ago, year and a half ago, I started with vigorous exercise with a trainer and an aggressive class, and I'm building muscle with no testosterone. I could do 1 push-up now. I can do 7 push-ups. I can press with my legs, 90 pounds, and I can press 300 with the leg machine. So it's not impossible. I was very surprised to see how much strength I've gained with no testosterone at all. Very interesting.
Good job,
Very
Larry.
good.
Working out
Yeah.
6 days a week, and
No,
really makes a difference.
that's a great testament right there. And what I wanted to say to you, Alan, just to echo what Dr. Jack said, is that testosterone notoriously jumps around a huge amount on a daily basis, within the day, from day to day. So don't be thinking, oh, I'm back down to 157. You could go in tomorrow and test, and you could test 320 again or 340. So
Okay.
it's not anything that's permanent.
Oh, that's good to know. Yeah, I'm looking at trends. I'm not thinking it's going to bounce around. So the fact that you folks have mentioned that gives me some the comfort that this is just going to be the nature of things. Very
Right.
good. Okay.
Okay, guys, this has been a great meeting. Thanks very much for everybody's participation. We kind of went all around the circuit here with a lot of different treatments and therapies and concerns for advanced disease, and we're all at different stages and tried many things. So, thankfully that hopefully we'll all be around for many more months this year and have some positive outcomes. I'm with you. So our next meeting, this is the second Monday of the month. So we don't meet again till
Hold on, Peter. This is the third Monday of the month. You remember that you're in the advanced group. You're getting yourself confused. The next meeting.
It's a second advanced Monday group of the month.
Yes.
Right. So
yes.
The next 2 Mondays will not be an advanced meeting. Is that correct? The next Monday meting will be in February?
Let's keep it simple for the guys. The next meeting will be next Tuesday, the 23rd, right? Yes, next Tuesday, the 23rd at 6 o'clock Eastern. Stay in the moment and we'll tell you when the next meeting is after that, at the end of that meeting. How about that?
Sounds good. Okay, thanks, everybody. Good night. Happy
Thanks,
Martin
Peter.
Luther
Good
King
job.
Day, what's left of it for you.
Good
Okay.
job, Peter.
Take
Good
care.
job, Peter.
Bye.
Thanks, Peter. Good night now.